Good morning. This is Steve Williams, the Chief Operating Officer with the Mental Health Trust. I'm going to keep this short because we have a packed agenda, but I just want to thank everyone who signed on for the second part of a three-part series on understanding the Medicaid block grant program. And I want to thank Steve again for moderating and facilitating this discussion, and Andy and Dennis for being online to share their expertise. So Steve, I'm going to turn it back over to you.
Okay, great. Well, welcome to everyone. This is the second session. I'm assuming that most of you had attended the first session. Right now we're up to about 108 attendees. The first session gave kind of a 101 of Medicaid block grants and what could be allowed under current law without additional legislation, and what might require legislation from Congress, from the federal Congress, to be able to enact. And if it's being done without legislation, then the vehicle that it would most likely be achieved under would be an 1115 demonstration waiver. So an 1115 demonstration waiver and negotiating that has two major components. One is figuring out the budget parameters and negotiating the budget neutrality. The second component is what you're going to be allowed to waive. What are going to be the terms and conditions? So what are you going to be allowed to waive? What are going to be the monitoring requirements, and so forth? This session is going to be focusing on the budget parameters and the process for negotiating the budget neutrality. The third session will be focusing on the key considerations for negotiating the terms and conditions. Now, in terms of the format for this meeting, we have less information to be going through on this slide deck than we do on the previous one, so that we're anticipating that the presentation will take about a half an hour. It may take a little bit longer, and then reserving the rest of the time for the questions. You can enter questions using the Q&A button that's on the bottom of your screen, and you can enter them at any time, but we're not going to start answering questions until after the review of the slides. We ask you then, if you have a question, if you can scan through to see if that question has already been asked. If it has, or if you think another question has been asked that you think is important, you can click the upvote button, which is that thumbs up symbol that shows up. It shows up fairly subtly to the bottom left-hand side. It's a little bit light in there, so you may have to look for it to be able to see it. You can also comment on the questions if you want to clarify a point within a question or add a related question on that, and then we can be adding that. Then the people at the Trust will be able to ask questions directly within the room. Now, we're going to be reviewing questions. We'll try to group similar questions, but we're going to focus on the questions that have the most upvotes first. Last time we were able to get to all of the questions, but we did go about 15 minutes over. That we're going to mark the questions that we believe that have been addressed in the conversation as being answered. On those, if you think a question wasn't addressed, please then ask the question again, possibly rephrasing it. You will only be able to speak if you're using your computer microphone and the host turns on your microphone. So if we're asking a question and then there's a follow-up point related to that particular question, there is an icon for raising your hand. So we will try to monitor if there's raised hands and to be able to turn on your microphone from that. I do note, however, that with this many people, we are scanning through everybody, but we apologize in advance if we missed anybody who had a raised hand. And again, we want to give the caveat that we won't necessarily get to every question, but we were successful last time, so I'm really hopeful that we will be able to this time also. Now, in terms of our speaker, the primary speaker is going to be Andy Schneider, who's a research professor at Georgetown University. And I'm assuming most of you were on the last time, so this will just be a refresher for you. Andy has been doing things with Medicaid for over 40 years as a congressional staffer, executive branch employee, doing private consulting, and a public interest attorney. Most relevant for this, that he was a senior advisor in the Center for Medicaid and CHIP Services, CMCS, under the Obama administration. And he led the development of the Medicaid resource book for the Kaiser Commission on Medicaid and the uninsured. The other speaker that we have is Dennis Smith, and Dennis is currently a senior advisor for Medicaid and healthcare reform at the Arkansas Department of Human Services, and also a visiting professor at the University of Arkansas Medical Sciences College of Public Health. He has worked for 4 different states, for Arkansas, Wisconsin, Virginia, and California. He also was a congressional staffer for 10 years. Most relevant that he headed up CMCS, that's the federal center that oversees all of Medicaid. He headed it up for 7 years during the second Bush presidency, so during George W. Bush's presidency, and he held that post for nearly 7 years, which is longer than anybody else has held that post. And in that tenure, he negotiated the sections 1115 demonstration projects with more than half the states. Before we proceed on, there was 2 questions that we wanted to follow up from last time that we were able to give you information on. The first question was on a question about Rhode Island, that Andy had mentioned that Rhode Island had gotten an 1115 that had a global waiver that was initially approved, but that when they went to renewal, they removed the global cap. And Andy Schneider did some background research on that, so I'll let Andy give an answer. Or the question was, why did the state decide to remove the global cap when they went for renewal? So let Andy give an answer to that question.
Thank you, Steve. Good morning, everyone. Thank you for joining us, and thanks again for the trust, to the trust for inviting me here. So again, Rhode Island had received approval and started implementing a waiver with an aggregate cap on total federal Medicaid matching funds to the state over 5 years. Under the waiver that started in 2009, and the first iteration of that ended in 2013 when the state sought renewal extension of the waiver. It did not ask for an extension of the aggregate cap, and the question was why. So I asked some people who were around at the time. I was not involved in this, and as far as I can tell, and I'm happy to be corrected if Dennis has additional information, but this really came down to a change in governors. When the waiver was initially approved in 2009, the governor was supportive of an aggregate cap, a global cap, and then the governorship changed hands, and the new governor was not supportive and chose not to request a renewal. I'm sure it's more complicated than that, but at some level, I think that pretty much explains it.
Okay. The other question that we had was Dennis said that it is about managing that risk, but is it all downside risk for the recipients, providers, in the state, and all upside risk for the federal government? If a state spends more than the federal government, and the more the federal government doesn't contribute more, correct? If a state spends less, the cap/block grant amount, et cetera, does the state get any of those funds back? And I'll throw that over to Dennis.
Thank you so much. Again, it's a pleasure to with you this afternoon. Thank you to the Trust for sponsoring us, and for my colleagues Steve and Andy. The question is, again, the difference between a block grant that is done through administrative authority, and then what could potentially be a block grant that Congress would enact. So in a block grant that Congress can enact, you're no longer, I think there is a version that the state could gain financially by being allowed to keep more of the savings due to that block grant. But that's a legislative proposal, and that's not what's in front of us today. The administrative approach, as we said last week and need to hasten to reiterate today, the Secretary does not have the authority to change the federal match rate. So we still have state dollars and federal dollars working together. So in the financial gain is not the same. The financial advantage to an administrative approach is that the state in this situation is really managing its risk. Right now in the first, there's always risk in Medicaid. You know, that is a given. The state is always at risk in terms of the obligations that it has taken on. The question to me is, does this approach give the state more tools under a waiver than the current Medicaid program has for the state? And to me, it's, can you mitigate, do you have more tools to mitigate against the risk that you're facing? And I think that you do, because by definition, if you wanted to run your Medicaid program exactly the way within the federal parameters, you don't need a waiver. A waiver is always saying whether it's an 1115 demonstration waiver or whether it's one of the waivers under the 1915 authority. The state is always saying, we want to be able to do something differently than what the regular Medicaid rules allow for. So again, this is really about giving more tools to the state to be able to manage their risk.
So I totally agree with Dennis about going to Congress if you want to use a block grant to, you know, capture some of the federal savings that you might be able to execute. The only point I disagree with him about, as those of you who were in the previous session know, is I don't think there's any authority for the Secretary to approve a block grant administratively. If there were such authority, Dennis would be right about that, but there isn't.
Okay, I think we can go ahead and then jump into the slides or today's slide deck. Okay, so I'm just going to start, and then we're going to march slide by slide like we did last time, and I, at the end, will stop and give Dennis a chance to comment. So this is just a recap of the authority that we're talking about and the authority that we have some disagreement about. So in the Social Security Act, which of course is where the Medicaid program is, Medicaid's in Title 19, but in Section 1115 is a separate authority that gives the Secretary the ability to waive federal Medicaid requirements to allow states to demonstrate new ways of running their Medicaid programs. And to do that, the Secretary has to find that the demonstration, and these are the magic words, likely to assist in promoting the objectives of the Act. And they're magic because they are the basis for litigation that's going on now in with respect to demonstration programs involving work requirements out of Kentucky and Arkansas and New Hampshire. In fact, there was just a hearing this morning on the New Hampshire case. So demonstrations are initially approved for 5 years. If the state wants to extend them, the extensions are available for 3 years at a time. The demonstrations have to be budget neutral, and that will be a major topic for conversation today. And there's a disagreement about whether this authorizes a block grant.
If I could add, and I certainly agree with all of the points that Andy has made, including the disagreement about the length and breadth of the Secretary's authority. But I would add, again, the words in quotes, likely to assist in promoting the objectives. There are two other important words in that bullet, which are the secretary. So again, I believe, and this is where we disagree, so there's not a whole, I don't want to belabor the point, other than bringing back the realization that the secretary is the only person who can make this determination. I would also say Congress has revisited the Section 1115 authority a number of times, including adding things in the process for 1115, such as a greater public comment, but they have never come back and said, they have never changed the authority of the secretary.
So that will give you an idea of the arguments that are going on before the Court of Appeals in the District of Columbia, where the Arkansas and Kentucky cases are now. We'll see what they have to say.
Okay.
We're not going to resolve them. That's pretty clear.
That is true. Okay.
Okay. So let's talk about this notion of budget neutrality.
But who would care? Or we could, but
yeah, touche. Excellent. So budget neutrality. So you're not going to find this in the statute, but there's been a long-standing, I'll call it a norm or a convention, or just that's the way the department has always administered the 1115 waiver, as far as I know, that if the state is going to get authority to use federal dollars without playing by all the federal rules, that the demonstration, the state has to show that the federal government is not going to incur more costs as a result of the demonstration than it would if the state didn't do the demonstration. So the magic terms here are with waiver spending. So how much is the federal government going to spend on Medicaid if the waiver goes into effect? And how much would the federal government spend if the waiver didn't go into effect, the so-called without waiver, or WOW, W-O-W. So in the process of deciding whether to approve a waiver or not, the secretary looks at projections, both of how would the program that the state is now operating perform over the next 5 years, and then how would it perform under the waiver from the standpoint of how much money is the federal government going to be matching state spending with. And again, this is, when you're, as Dennis will tell you, when you're as a state negotiating for an 1115 waiver, this is one of the elements of the negotiation. We'll do a whole webinar whenever we're doing it next in August on some of the other elements, like what specific rules of Title 19 will the Secretary waive. This is one element of a broader set of negotiations, but it's a pretty important one.
It is indeed. If I could add just one additional point, again, agreeing entirely with everything that Andy has just said. The measurement is, and again, the key words in the bottom of the last bullet there, over the 5-year period. So you can negotiate a waiver that is not budget neutral. And again, budget neutral only means you have to save at least $1 compared to the baseline over the 5-year period. So waivers, in fact, have not been budget neutral, not many waivers. On a year-by-year basis, the federal government, in fact, spent more than what it would have without the waiver, but over the 5-year period, it was budget neutral.
Absolutely correct. Okay, so now we're going to dig a little deeper into these budget neutrality policies, and I'm just going to say up front, it's a lot more complicated than what we're going to walk you through, because there's not enough time in the afternoon to go through all of it. If you're a glutton for punishment, there's a site, a link there to a 10-page single-space letter that came out in August, this past August of 2018, to state Medicaid directors, setting forth the considerations that CMS follows in deciding whether a waiver meets the budget neutrality test. And I just want to quote one statement from there, for what it's worth, that in the letter, CMS is emphasizing to state Medicaid directors that the overarching goal of budget neutrality, quote, is to limit federal fiscal exposure resulting from the use of Section 1115 authority. That's a polite way of saying we're not going to give money away here. We are concerned about, we at the federal level are concerned about how much money is going out the door under these waivers, and we have a lot of rules that are designed to protect our interest. So that is the publicly articulated framework into which, if Alaska chose to pursue this, they would be walking. So anyway, to oversimplify, there are two basic ways that budget neutrality is calculated. The more common way, for example, most recently in Utah with their per capita cap waiver that we mentioned last time, it's based on spending per eligible individual per month. And the upshot of that is if enrollment goes up, the budget neutrality limit goes up. And because the state is not at risk for increases in enrollment for whatever reason. Bad economy, changes in eligibility, changes in administration, doesn't matter. The state is at risk for the per person per month cost of an enrollee, but not for the number of enrollees. And so we're gonna focus on that because that's the most common. The other option is this what's known as the aggregate cap, and there the state is also at risk for enrollment costs above the level of the cap. So that's the big difference. And to Dennis's point earlier, the secretary under either approach doesn't have the authority to change the state's statutory matching rate. Either the 50% for most populations in Alaska's program now, or the 93% going down to 90% for the expansion population. Those are fixed. I don't know, Dennis, if you wanted to add anything.
Yeah, just add my total agreement. It's far more complicated than this slide appears. So Andy did a great job summarizing the data that goes behind these calculations on a per capita basis, for example, child, adult, individual with disability, whatever population is being included in the waiver. But the rate cells that are in many respects trended on a month-by-month basis, really. You will need to hire an actuary to help you with these negotiations.
So speaking of actuaries, you have up on, the state of Alaska has up on its Medicaid website something called the Medicaid Data Book that's prepared by Milliman, which is an actuarial firm. And if you want to see what these member months per member per month numbers look like, they're very detailed. They're broken down by tribal and non-tribal members. They're broken down, as Dennis mentioned, by populations, low-income family, Medicaid expansion, male, female, pregnant women, SSI disabled. And if you just want to get a feel for what's going on currently in your program, at least for state fiscal year 2017, it's right there on the website of that report, and very, very, detailed tables. Again, we don't want to get that complicated here, but just so you know, these constructs, the per member per month notion, the member month notion, they're commonly used now, both for the state's own purposes and for purposes of negotiating budget neutrality under an 1115 demonstration. Okay, so again, to oversimplify, what are we doing? First, we have to figure out who the populations are that are affected by the demonstration. In Alaska, if you go to the Alaska dashboard, they break down categories for disabled children, disabled adults, parent caretakers, seniors, and expansion. So those are 6 different categories. You would decide which of those categories you want to include in a block grant. And then for each group that you decided you want to include in a block grant, you project enrollment, you the state project enrollment for each demonstration year. And that's this concept of member months. How many months per year will enrollees be eligible for benefits? And because of course there's turnover, and so not everybody's eligible for 12 months of a year. But you can see that over time, and you can see that some populations turn over more than others. So maybe on average, one individual is eligible on one type of population. Say, I'll just make this up. Parents are eligible, 10 months on average for each parent who's enrolled, and kids are eligible for, I'll make this up again, 11.5 months for each kid who's enrolled. So you're going to get different member month numbers for each population. That's the only point. It's the population group specific calculation. And then again, you need to know, so what did each group cost? And you're going to get quite a range between the cost for the seniors, the cost for individuals with disabilities, the cost for kids, the cost for parent caretaker relatives. But there is going to be a number, and you can see it for state fiscal year 17 in the Milliman tables. Because of a large number of tribal members, the Milliman tables also break it down by tribal and non-tribal. So all of those data points become relevant, and the issue is trending them forward for the 5-year period for the demonstration.
I think that's a great chart and a great summary. I would just emphasize one other point. Calculating without the waiver sometimes might get overlooked a little bit because everybody wants to jump forward. What are we going to do with the waiver? But the absolute importance of saying, and again, you're calculating without the waiver based on past data. So these are the trends that are happening currently in the program, but we also know this is going to happen in the next couple of years or whatever. So you bring in other information about your demographics. How quickly is your population aging? How quickly are changes going to happen over these next 5 years in the absence of the waiver?
Okay, so now, picking up on this point, how quickly are things going to change? And the technical term for that is a trend rate. It's basically a percentage change each year. And so in order to come to an agreement around budget neutrality, there has to be an agreement not just on the number of member months, is that data accurate, the number of the amount per member per month spending, but over each of the 5 years of the waiver period, are the trends over that time something that we, the federal government, and you, the state, can agree on. So there'll be a trend rate for the number of member months. There'll be a trend rate for per member per month costs. And of course, this is specific to each beneficiary group that you decided to put into the block grant. I've just put the CBO projections. They're not specific to Alaska. Your trend rates would be specific to Alaska. But just so you get a feeling for this, so for non-disabled adults under 65, right now, the Congressional Budget Office nationally for all federal spending in all states is projecting a growth of about 0.7% per year in the number of member months. And similarly, if you're looking at per member per month costs for that same population, non-disabled adults under 65, CBO is projecting that nationally, that's going to increase about 5.3% a year. And again, you'll have different numbers. These are just illustrative. You'll have different numbers because the administration has its own numbers, doesn't necessarily buy the analysis that the Congressional Budget Office uses. And so that will be part of the mix. You'll bring your numbers, they'll have theirs, you'll have to work it out. And finally, to the point that Dennis alluded to, so to get to some of these projections and to give the federal government that there's something real behind the numbers that the state is proposing, the state has to go back and present historical data. So per member per month and member months for a 5-year period for the most recent time for that, which that is available. And in Alaska's case, I assume the state would go to things like the Milliman Medicaid data book for SFY 17, SFY 2016, and previous years.
Just to add another quick point, again, the Congressional Budget Office, when you look at their baselines, they project only federal spending. They do not do state-by-state projections. So CBO's numbers are an average, which means they don't apply to anybody in reality. So again, the importance of making your strongest case to CMS about what is happening exactly in your state.
Correct. Okay, I'm going to let you read the Dilbert first, and then tell you what's going on here. So, and Dennis has had a lot more direct, personal, up-close experience with these negotiations, but the overall framework is, again, as we said, the total cost with the waiver for the federal government can't be greater than the total cost without the waiver over the entire 5-year period. So they might be greater in year 1 and year 2 if the waiver is front-loaded in terms of federal dollars flowing into the state, but over 5 years, the federal government can't be spending more with the waiver in effect than it would have if there were no waiver granted. And so the state will propose some assumptions, we'll call them, about how member months or per member per month costs will or won't change. And again, as to emphasize Dennis's point, the state is also going to need to demonstrate and document its historical rates as reasonable projections going forward for what happens if no waiver is granted. And then there has to be an agreement between the state and the federal government over the per member per month numbers, the member month numbers, and the trend rates for each of the populations for each of the 5 years.
Just to share a little bit of inside baseball with you, in that, and again, I have the scars to show for waiver negotiations, and part of the issue is while you're talking directly to CMS, you never know what OMB is saying back to CMS. You don't, OMB is always in the room, you just don't know they're there, and you don't get the benefit of their feedback. So oftentimes CMS will help try to coach you because they are hearing from OMB, they're hearing OMB's arguments. So again, you ultimately OMB, there's nothing in law, there's nothing in regulation, but knowing up front that CMS is not the only one in the room that you have to convince.
Which is a perfect transition to the next slide. Not only do you have to convince OMB, but there are also some CMS actuaries. There's the CMS leadership at the administrator's level, and of course the secretary who's signing off on this also often has more than a passing interest. And occasionally, depending on the type of waiver and what's being asked for, there may be other agencies within the department brought into the discussions. For example, with the substance use disorder waiver that Alaska got last year, it's possible that that SAMHSA, the federal agency that does a lot of work in that area and runs one of the block grants that applies to that population, was involved in the conversations. I don't know, but that would be an example.
And I would say that this is a little bit of a change than when I was there. We did the CMS actuaries were really did not play the role that they do today. So that is part of the evolution. Generally, the Office of the Actuary was not involved, other than maybe some ad hoc discussions and technical support. But they are much more involved today than they were in the past. And I would say also, I get such a chuckle out of every time I see this slide. That's a brilliant slide.
Yeah, kudos to our slide maker, Steve Lutsky. I would never have the creativity to come up with that one. That was good.
Yeah, me too. That was great.
Okay, so again, what you're looking at here is just to try to illustrate how this works. Using very simple, totally made up numbers. It doesn't matter whether this is with waiver or without waiver. The only point of this is so you can see how the math works. So at the top column, you see we've got a trend line column. Top row, I'm sorry, we've got a trend line column, and then for each demonstration year, each DY, 1, 2, 3, 4, 5, we're going to look at member months, we're going to look at per member per month, and we're going to look at total spending. And then in the very last column, that will give us a 5-year total. Okay. And again, these trend lines are completely made up. So I'm just doing 1.0% growth in member months each year over the 5 years. And we're just going to make up a number. We're going to start with 100, and you multiply 100 by 100.1. I'm sorry, 101, and it just sort of marches up. You add 1 percentage point growth to each to 100, and round it off. It sort of marches up 101, 102, 103, 104. That's a 1% growth rate. So by demonstration year 5, your member months have gone up to 104 at that trend rate. Similarly, per member per month, a totally made up number, $600. Now we're going to grow that at 5%. And so we're going to multiply by 1.05. So when you multiply 600 by 1.05, you get 630. You multiply 630 by 1.05, you get 661, and on. Okay, now you take the number of member months and you multiply that by per member per month. And you get a total spending projected in the first year on those assumptions of $60,000. And again, you multiply in demonstration year 2, the 101 times the 630, which have now both been increased by 2 different trend rates. Now you're at 63,630. And you keep marching down, doing those same multiplications, and then you end up with a 5-year total. And again, it's that spending over 5 years, not necessarily what happens in year 1 or 2 or 4. It's the spending over 5 years. That's the magic number. But this, very simply, is how you build to it, combining member months. You need a starting point for member months. You need a trend rate. Per member per month, you need a starting point for per member per month spending, and you apply a trend rate, and then you multiply the 2 for each of the 5 years, add that all up, and there you are. Of course, in the real world, it's not quite this easy, but I think this is a fair summary of of conceptually the way it works. Dennis, you have anything else on this?
No, I was just going to say simple math, great way to simplify. The concept is a great summary of all of the complications behind it, but ultimately it is just simple math.
Okay, so now the first question is, what are the state costs that are counted towards the block grant spending limit? Because again, the exercise here is to figure out how to agree upon a spending limit, and the first question is, who's covered by the spending cap? So these are some of the questions, some of the beneficiary group choices that you have. And of course, there's in a state like Alaska with a significant tribal population, you have the question as to whether they're going to be included or not. Again, to the extent a population is included, then you have to go through that exercise we just went through. What's the estimated member months? What's the estimated per member per month spending? And how does that look with waiver and without waiver over the 5-year period of the waiver? Related to this is, so what services are we covering here? Are we covering acute care services like hospital and physician and clinic and prescription drug? Or are we covering nursing home care or home and community-based services, or the prescription drugs associated with those populations, or both? What about the home community-based services that are part of waivers that the state already has? How are those to be treated? Again, these are all design issues that the state would want to think through, and that would then be negotiated with the federal government. But whatever services go in obviously drive per member per month spending. If you're not including nursing home care, then the costs of nursing home care are not in per member per month spending, right? Then there's this issue about payments that are not tied to a specific patient. And among the categories of payments like this are disproportionate share hospital payments or supplemental payments to hospitals or nursing homes. And those tend to be lump sum payments, but whether they're lump sum or not, they're definitely not tied to an individual visit or an individual service provision. And again, you need to decide, because they do represent federal expenditures as well as state expenditures. You do need to decide how they're going to be treated for purposes of this demonstration. And then finally, you have the question of administrative costs, because while Medicaid is a relatively efficient program compared with private insurers and Medicare, it still costs money to administer the program because it's complicated. And right now, those costs are matched on an open-ended basis. As a general rule, at 50% match, but there are some special administrative costs for management information systems or fraud control units, et cetera, that are matched at 75%, or in some cases even 90%. In any event, you need a decision on how to deal with those expenditures.
I would only add that these are the toughest questions for you all to ask and answer for yourselves. It's not one that we're going to help you with.
Well, I'm not helping them design a block grant at all. I'm just explaining what they had to do if they wanted to do it.
Exactly. The last part is then when you start looking at the with waiver, what is it you are going to do to change the trajectory of these things? So again, you're going to introduce other reforms in your service delivery system? Are you going to, now that you've decided what services, what beneficiary groups, et cetera, you're going to include, the second part of the negotiations turns into, well, how are you going to change that?
Okay, so we've gone through this pretty complicated exercise of deciding who's going to be covered, what services are going to be covered. We've come up with a budget neutrality limit based on that. We've adjusted for any other changes we're making in delivery system reform that might affect any of those trends. And now we have limit. And what happens if the state is drawing down federal matching dollars above the limit? For whatever reason, it just reaches the limit. So the first point is, in the final waiver approval document, there are a whole list of what are called STCs, special terms and conditions. And it's that set of terms and conditions which lay out all the details, including what happens if the state violates budget neutrality. So here's an example. This is a waiver that the state now has. It was approved in last November. It's STC 68, and here's what it says about exceeding budget neutrality. So the budget neutrality limits calculated in STC 58 will apply to actual expenditures for demonstration services as reported by the state under Section 11. Because, of course, the SDCs would also spell out the reporting protocols, requirements, and timing. And if at the end of the demonstration period, that'd be the 5-year period, the budget neutrality limit has been exceeded, the excess federal funds must be returned to CMS. So that's point one. And if the demonstration is terminated prior to the end of the demonstration period, say after 3 years instead of 5, the budget neutrality test must be based on the time period through the termination date. So you look at the first 3, DY, D2, D3, DY1, DY2, DY3, and you see what the budget neutrality limit was after those 3 years. If the state exceeded that, the state would have to pay the federal government back. If it didn't, and there wasn't any excess federal payments, then the state could exit without repaying the federal government. But the state can always exit. I mean, that's the basic point. It can always terminate. It's just a question of where is it in its spending pattern relative to the budget neutrality amounts that it has agreed to that are spelled out in the special terms and conditions.
And I'll just emphasize this point as well. The state does have to go into the expectation that the federal government is serious, that it wants its money back for anything that exceeds the budget neutrality limit. And there is history of the federal government doing that. So it is not to be taken lightly to say, well, when we negotiate the extension, we'll somehow ease the pain by getting favorable or accepting tougher terms the second time around by reducing that. Do not go in with that perspective. The idea that the federal government, in fact, will require payment of excess funding.
Dennis is absolutely right. I just want to emphasize that. And for detail, take a look at this August 22nd, 2018 State Medicaid Director letter I talked about earlier. There are several pages there that explain how they're changing the rules about not being so generous in rolling over savings or allowing excess funds to be ignored, et cetera. Because things have been changing on the federal level as well, and it's pretty clearly reflected there in that letter.
And the reason for that is because you have a number of states that, in many respects, treated their savings like a big bank account, and they would come to CMS and say, "Look, I've got $5 billion saved up, so now I want to use my savings." And frequently, CMS would allow that argument, but that is a very significant and from my perspective, a correction to the system, not to let prior year balances, because again, some of these states would go back 10 years and say, "Oh, I've got all this money saved up, but now you have to let me cash it in."
Yeah, under this letter, those days are over.
Okay, so that is our last slide. We do have 2 questions that have been put in. One has a number of upvotes. So that question is, when calculating various projections for a waiver, member months, per member per month, trends, etc., would a state be locked into the initial projections for a full 5 years, or does the waiver allow you to refresh the numbers comparing trends and actuals? Our economy tends to be counter-cyclical as compared to the lower 48. in the last couple of years, the Alaska Medicaid program saw a big jump in enrollment due to the ramp up of Medicaid, but also the recession we've been experiencing. If we were under a waiver for a block grant, would we have been able to recalculate the impacts? So I'll throw that to Dennis.
Well, in general, you do not get to renegotiate the waiver during the existence of that waiver. And again, that's why I need to be very careful about predicting things, and to the extent to which you can, part of this spills over into the next session. So thank you for the question for that, in the terms and conditions. So you can't, I have seen parameters to be built in. I wouldn't, maybe a safety valve is not the correct way to describe it, but the potential for adjustments within certain parameters. But you would need to negotiate those parameters at the beginning. Now, you could then come say, it just didn't turn out. And this is the importance of monitoring, and something I've also seen, but in the past, to sort of, well, we're just going to let it ride for 5 years. Again, that's the wrong approach to take. This needs to be monitored carefully on a monthly and quarterly basis to make certain you know where you stand financially. As I said, typically, if you, anything to anything to monitor within parameters need to be negotiated at the beginning.
I agree with Dennis, and my personal takeaway is be very careful what you ask for.
And for those of you on the webinar, I'd encourage you to enter other questions into the Q&A. The other question that we have is that states have promised budget neutrality over 5 years and spent more money for program changes that are supposed to be productive, or supposed to produce net savings. How often does that really happen? Has CMS ever penalized a state for that failure?
Yes.
Do you have any sense of how often that they actually meet the budget neutrality versus, and Dennis, I imagine you might have the most sense of it, versus how often do they actually kind of miss it?
I haven't studied the waivers closely enough to know what has happened in more recent history. And again, I think part of that is a reflection in the new parameters that Andy read in that SMD letter, which does, and CMS has taken a fair share of criticism from the Government Accountability Office, for example. So the way budget neutrality has been calculated over the years is not without its own controversy. I think that it is fair to say the rules have been tightened up over time to provide additional protections for the federal government. Andy, did I answer that diplomatically enough?
Yes, no, I think that's correct. It's a good question. I'm just not enough of a historian of 1115 waivers to give you an intelligent answer. I just don't know. But the point that things are changing at the federal level, that's indisputable. So whatever the historical record was, I'm not sure how good a guide that would be going forward.
Okay. Great point.
We have another question. As one of your slides says, we are just getting going on part of an 1115 waiver for behavioral health. Would the without waiver computations for a future block grant waiver include spending as projected for a behavioral health waiver or as projected for operations without the behavioral health waiver?
I'm guessing, which I probably shouldn't guess, so I'll just display my ignorance. I guess I would be interested in hearing more about why you're pursuing an 1115 waiver for those services. My guess is to be able to fund the IMD because of the IMD exclusion, and the administration has put out guidance that is one way. Funding through the institutions for mental diseases for adults could be, the cost of that could be recognized. As I said, that's my assumption, is you're pursuing it because of the IMD money.
And I think the larger question would be whether if they started, and first of all, maybe we can break it into a couple of components. If they are starting an 1115 for a block grant, should that be different than the current 1115 for behavioral health, or should the 1115 behavioral health potentially be expanded to include this waiver? And if they are separate 1115s, have you seen examples where the populations overlap? So you would have the behavioral health run under the 1115 for this effort, which expands some of the community-based services and adds an administrative service organization, and also might be covered under another 1115 waiver. I'll throw that to everyone. Go ahead.
I'm just going to say I just don't know enough about what your current waiver is or what you have proposed to give you any. I'm just going to have to take a bye on this because I just don't know enough about what has been proposed. So.
Okay.
In fairness to Dennis, I'll take a bye on it too. How would anyone know? I mean, really, this is a question of first impression, as we like to say. Like, nobody's tried this before. And so I think both the state and the federal government would have to feel their way through this. Some of the questions you'll have to ask, right? Are we including the population that's in the SUD waiver that you've already got in the block grant waiver or not? Are we including the services, IMD or otherwise, in the block grant waiver or not? Some of those questions you'd have to answer as a state when you're proposing. But is that the right answer? Nobody knows. There's no precedent, right?
But if they do decide to include mental health services and the mental health populations within the broader 1115 under a block grant, then would you anticipate that the existing 1115 for the block grant would then be subsumed within the larger 1115, or the existing 1115 for the behavioral health would be subsumed within the larger 1115, or would you anticipate that there might be two separate 1115s that would have an overlap of that population?
Yeah, to me, it really is a state issue, and I've said this many times. CMS cannot approve a waiver that a state does not submit to it. You all are going to decide that issue of whether or not you want to present that to CMS.
I agree.
Good. That's good guidance. Okay, we have some other questions that are coming on. Seeing the way things have been managed throughout the past years, I do fear that the state will sit on it for 5 years. The cuts they need to make are too great and will devastate our communities. Very concerned. Leave that, it's not really a question. See if Andy or Dennis have a comment in response to it.
I'm sorry, I just didn't understand the point. It just went by a little too fast. Can you try it again?
Sure. It's seeing that the way that things have been managed throughout the past years, I do fear that the state will sit on it for 5 years. The cuts they need to make are too great and will devastate our communities. Very concerned.
I guess I don't understand it. I'm sorry.
I think they're concerned that the state, if they got an 1115, would not take action within the very quickly to build the infrastructure for making the changes, and that they're concerned overall in Alaska about the amount of cuts that they potentially have to make just because of the size of their overall state budget deficit. Okay.
Well, as we discussed in the first session, I personally don't think that a block grant is the solution to a state funding crisis. I think it just makes it worse.
So again, I hesitate to, I'll say it this way. I am very state-centric, that the state and all of the constituency groups, beneficiaries, providers, et cetera, have to make that decision jointly. But you can do it only because you understand the unique circumstances that you have. If the waiver with its budget neutrality can be a forcing device, because everybody then understands we have collectively decided we are going to live underneath this funding restraint. So therefore, we all have to, but it's a pledge you have to make together at the very beginning of the process, would be my advice. I have seen it in, but a per capita cap can also, a per capita cap or an aggregate cap in some other part of the program, or a limited part of the program. Here in Arkansas, for example, our qualified health plans that enroll and cover our Medicaid expansion population, they know precisely where that budget neutrality per capita cap is every year. They know precisely they have to live underneath that cap. But again, it is part of the commitment, the collective commitment everybody has to make at the beginning. Those per capita cap, they're not a surprise to anybody. They're not a surprise to the providers. They're not a surprise to the QHPs. Everybody knew at the beginning of how they were going to be able to live within those constraints. But that's a very public process that needs to be done.
We have another question. Can tribal services and reimbursement be excluded from the waiver cost neutrality provision? I'll throw that one to Andy.
Again, this is a design issue of what the state wants to propose to the federal government. You would have to make a decision. Should certain tribal populations be in or out? Should all tribal populations be in or out? Should certain services for tribal populations be in or out? Should all services to tribal populations be in or out? The state has to decide what it wants there. Then how the federal government would react to that, you know, I'm sort of reluctant to predict. The only precedent I have to point to recently in the current administration, because I'm not sure how how the previous administration, how valuable those precedents are. But in the current administration, in the context of work requirements, demonstrations, Arizona and one other state, I'm blanking on it, I'm sorry, but Arizona has gotten approval from CMS to exempt American Indians and Alaska Natives who would otherwise be covered by the work requirements from those requirements. And that was after an extensive internal debate about what some of the lawyers saw as the civil rights implications of that. But in any event, that's the only precedent I know of from the current administration. So it's possible that they would be willing to look at an exemption for tribal programs, tribal members.
Okay. And Dennis, did you have any follow-up comments?
I agree with Andy, and it's an issue that has gone back and forth over quite a bit of time. So there's nothing, because it's been inconsistently viewed. I would say there's nothing specifically to point to say this is exactly where CMS would come down. So just agree with Andy.
Okay. Next question is, does a block grant target population have to be an entire eligibility category? Or could a state look at a block grant for a very specific population, for example, high utilizers of the emergency department? I'll throw that to Dennis.
Generally, you look at Medicaid eligibility groups, looking just at high utilizers. I mean, how do you predict who they are over time? So you can target specific groups. It's not an all or nothing proposition in terms, but they generally do follow everyone within that group. For example, the Medicaid expansion population. You're dealing with all adults, higher than the state's previous income threshold for parent caretakers of children who are on Medicaid, plus the childless adults up to 138% of poverty, for example. So you generally do identify what group you want to target, but in general, that has been along an eligibility group rather than again, a category of high utilizers. They might have been high utilizers this year. How do you know who they're going to be next year? So that one to me is a bit unpredictable, looking at it that respect. And there are other ways to look at specific groups in terms of utilization. For example, we have created a new program here in Arkansas directly for people with high needs of behavioral health services and for people who use our waivers with developmental disabilities. But those are identifiable groups because you can run the data. They go through an independent assessment to determine who they are up front. So I think you need some kind of mechanism like that to determine who would be who would be your demonstration group.
And Andy, do you have any follow-up comments?
No, I agree with Dennis. I think the way CMS has traditionally thought about demonstrations under 1115 has been in terms of groups, not in terms of types of individual patients with certain high utilizing behaviors who may be in different groups, you know, maybe kids, maybe adults, maybe parents, maybe people with disabilities. They're all high utilizers of emergency services. It's just not the way that the agency has approached it. The other point I'd make about it is, of course, everybody has an interest in reducing high utilization of ERs where it's possible. There are some things that are available under current law that don't require any waiver of any kind. You want to be sure you're doing those. And then there are waivers that you can have to apply additional interventions to high utilizers. But again, you don't need a block grant as part of that waiver. To solve that specific problem, I think conceptually it's hard and it's far more than you need.
Okay, great. Kelda, are there, I understand there's questions in the room, so I'll turn it over for you to facilitate that. And if you're speaking, you might still be muted.
Hi, Steve. Can you hear us now?
Yep, we can.
Yep, we can. Great. The first question is, how do states need to address mental health parity?
I'll throw that to Andy first.
In a block grant?
Yes.
So I'm not sure I can do that off the top of my head. I don't think, Dennis, correct me if I'm wrong, I don't think mental health parity is a state plan requirement specifically. Generally, because it's federal law and states are receiving federal financial participation, I think they're required to comply, but I'd have to go research it. I'm sorry. I don't even know if it's something that's waivable. Because again, in order for it to be waivable, it would have to be in Section 1902 of the Social Security Act. And I just don't know off the top of my head where mental health parity is.
Yeah, I agree with Andy. It's a requirement. So again, in terms and conditions, states generally are attesting that they are in compliance with a relatively robust list of federal laws, including mental health parity. So in general, the state is going to be told you're going to have to show, in fact, that you comply with mental health parity. We again did that in our approach for our behavioral health population to meet that assurance and how you meet it. So.
Okay.
Thank you. We do have two more questions that appear to be related to some design choices, so I'll ask them both at the same time. What happens to the CHIP program, and what does a block grant do to optional services?
Well, again, I think that's what how are you designing what populations are in and what services are in, at the beginning. There is, Secretary has the same authority on Title 21 as the Secretary has in 19. So they can be put into a demonstration project. But again, those are design issues up front for the state. I would say and I think I made this point on the last one, the mandatory versus optional services. I am not aware of any mandatory population or mandatory service that has been waived, with the exception of the Oregon going back to the late 1990s in waiving EPSDT for a certain population. But optional services, again, there are many people would contend that even though, you know, the Medicaid statute was written in 1965, right? Prescription drugs were not generally reviewed at that point in time as they are today. Medicare didn't even cover prescription drugs until the law was passed, outpatient prescription drugs, until the law was passed in 2003. So while legally are prescription drugs optional, yes, but how are you really going to run a modern program without prescription drugs? Again, many services that are optional, they're optional because they are an alternative to a higher cost setting. Home and community-based waiver services, for example. Those are less expensive alternatives to a higher cost mandatory service being nursing facilities. So I'm afraid it's going to sound like I'm taking a bye on this one, but that one is not that one's not an easy distinction between mandatory and optional. And you know, again, there are a number. There's a difference between can you do it legally and can you do it and have a program that serves Medicaid population appropriately. You know, I have advocated, and I have often said, Medicaid was written in 1965. Home and community-based waivers we've had since 1981. You know, there does, I think, become a time when the program itself has to keep pace with the population it serves. So sometimes states are left with this, you know, we are still facing an old chassis. You know, it's like a can you update it? Can you update it with new software? Do you have a chassis? You have a framework, but you can continually update it within that through the software system. What is how much can we update it within the parameters of the requirement of the Act and within waiver authority through 1915, for example? How far can we get using those more time-tested alternatives?
So just a couple of comments. Totally agree with Dennis on the optional services. That's a state design issue. There's a question about what's optional or mandatory, but it doesn't matter. You have to decide which services are in or out because you have to build your PMPMs. CHIP is already a block grant. And just one thing I checked while during this conversation for mental health parity in what I think is a pretty up-to-date index of the Medicaid statute. It's not in Section 1902, which is what the Secretary is authorized to waive under the demonstration authority. There's a requirement that if you offer benchmark benefit packages to certain populations, then you have to comply with Title 27 of the Public Health Service Act, where the mental health parity language is. And there's also a separate requirement that Medicaid managed care organizations, these are the risk-based managed care plans, which you don't have in Alaska right now, also have to comply with mental health parity. But there's nothing in Section 1902.
Okay, Kelda, any other questions in the room? Okay, I'm going to go back online. We have one other question saying, under a block grant through an 1115 waiver, would the state be able to make monthly determinations about where they are at in the enrollment against their projected numbers, and then decline enrollment of people who are not enrolled under the federally mandated populations? I'll throw that one to Dennis.
Well, again, there have been waivers granted that put enrollment caps on optional populations. To my knowledge, there has never been a cap for mandatory populations. So to my knowledge, no state has ever proposed it. No secretary has even considered it because it hasn't been proposed. From discussions during, when we did have discussions, we never considered any enrollment cap on mandatory populations. On a waiver population, again, when you go to the expansion group, can you propose one? Might the secretary approve it? I would say the current administration might consider it. The Obama administration, when I was in Wisconsin, permitted an enrollment cap on our optional adult population that was covered under a demonstration. So there is precedent for capping enrollment of optional adult populations, non-disabled, non-elderly.
Okay. We have one more question in the queue that will make that our last question. In webinar 1, we talked about the fixed annual allotment of federal matching funds and that there is no individual entitlement to benefits. Would a state be required to pay for care if it ran out of federal monies? Or is access to care for Medicaid recipients stopped until a new federal fiscal year? Under a block grant, it seems that the only real measure of success is the bottom line with no regard for outcomes. Under a block grant scenario, a state's Medicaid program would be more focused on managing the monies they receive from the feds versus looking at the healthcare outcomes and opportunities to reform the program. Trying to understand a reason why a state would take this level of risk. But I think the first part is the question where they're asking about would a state, if they are running out of the matching funds and there's no individual entitlement of benefits, if they ran out of the federal monies, would they be required to still provide the care, or could they not allow access to care until they had new federal monies in another fiscal year? And I will throw that one to Andy.
So the federal law in this case would be what's in the waiver, right? And presumably the waiver would make it clear that the state wasn't on the hook. Otherwise, hard for me to understand why a state would get into that situation. I can't speak to what Alaska state law would provide. And again, as you know, I don't think the secretary has the authority to approve that kind of an arrangement in the first place.
And Dennis, did you have any comments?
Well, again, there's a lot of what ifs in the question. Yes, certainly the state should know on a month-to-month basis how it is coming out and whether it's managing the program. As Andy said, how you would deal with it should be negotiated in the terms and conditions. Typically, that is again, spelled out in different ways. Can you cap enrollment on the optional adults, for example? So you're not affecting the entire population or the entire array of services for the entire population. You are saying up front, how are we going to manage that? Typically, as I said earlier, the federal funds are going to continue to flow. Federal dollars are drawn down on a quarterly basis, so you're looking quarter by quarter. The federal government will not cut you off quarter by quarter because budget neutrality is over the 5-year period of the waiver, right? So, but that's not to say you don't have to worry until the last quarter of, quarter 3 of the 4th year of the waiver. Obviously, that would not be advisable, and nor would the state or CMS really do that. So, so the federal funds are not going to get cut off. In the terms and conditions, there's always a term and condition on how to end the waiver and the obligation of the state to end the waiver. So those are things that are dealt with in terms and conditions, which is a segue to make certain everybody comes back for session 3, in which Andy and I.
That is a perfect segue.
That was nicely done, Dennis. Very well done.
So we are at the end of our time. Do either of you have any closing comments?
Just to thank you, Trust, and Andy for a wonderful way to spend an hour and a half.
Great.
I enjoyed it. Thanks.
And thanks to you both. We very much appreciate you sharing all of the information and especially the collegial approach that you take to the topic. So thanks all of you. We will be taking a little bit of a break. We're going to be coming back in August for the final session. And you can register on the Trust website. You will be getting an email that has a link to the actual presentation and to the recorded version of this if you do want to listen to it again. We also encourage you to register for the final session. Thank you very much and have a good rest of your day. Yes.
Steve, be sure to tell them there'll be a pop quiz in the final session.
Okay, we'll have to come up with a pop quiz then. So thank you very much. Have a good rest of your day.